Welcome, and thank you for joining us at today's Road to Excellence Specialist Accreditation Workshop. In the spirit of reconciliation, PracticeHub acknowledges the traditional custodians of country throughout Australia and the connections to land, sea, and community. We pay our respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Thank you for joining us at the latest PracticeHub webinar. We have had yet another overwhelming response to this webinar, so clearly it's a topic of much interest. And we have a great panel with us this evening who will be addressing some of the many questions which have come through during registration, which we thank you for. On our panel this evening, we have Amanda Ginger. Amanda is the National Manager of Clinical Services at Quality Innovation Performance Limited. Amanda has comprehensive experience preparing organizations for accreditation against various health and quality focused frameworks and is an active NSQHS Standards assessor for multiple accreditation organizations. Joining Amanda, we have Anna Maria Gibb, the co-creator of My Practice Manual, now PracticeHub. Anna Maria has a background in practice management and qualifications in business and adult education. I will now hand over to you, Anna Maria.
Terrific. Thanks, Katrina, and welcome everybody. I know it's probably the end of a very long day for everyone, so thank you very much for giving up your time to join us this afternoon. So as Katrina mentioned, Amanda Ginger from QIP is joining us this evening. Amanda will be talking about the National Safety and Quality Health Service Standards, their purpose and structure. Amanda will also be talking about the top 5 areas for non-compliance. And at the end of the presentation, I'll run through PracticeHub and talk about how it links with supporting your accreditation or process as well. So without further ado, Amanda, can I hand over to you?
Thank you so much. And again, I'd like to pay my acknowledgement as well to the traditional owners of the land upon which we're all meeting today. And you can see behind me, when I'm at the office at QIP, I'm at the Turrbal Yagara Nation, which is in Brisbane, around Milton, where our office is. But tonight I'm in the Yagambie Nation. So I actually live on the Gold Coast, and just talk a bit about QIP and AgPal, the company for which I work for. So AgPal and QIP, we do the standards across a whole lot of different schemes. So the AgPal, you'd all be aware of with GP accreditation, and QIP, the other arm of the business for which I work, we do the national standards, NDIS, Rainbow Tick, ISO, HSQF, lots of different accreditations. So, and most recently we're doing child protection as well. So we're quite a small company doing a whole lot of work. And so that's who I'm representing today. My own background, however, I'm a nurse by profession. I did hospital training back 100 years ago when Noah was playing football. And I'm from Victoria, but now live in Queensland, as we discussed. And I work only in accreditation space at the moment. So either assessing organisations or consulting on the other side and getting organisations ready for accreditation. And so this is a big passion of mine. So I want to talk about the national standards and where they actually came from. Sorry, this is a list of us bragging about how many frameworks we do. So I wasn't going to remember that whole list, was I? You can see there the list of all the sectors that we go through as well. And that's why I know we're speaking with specialist and specialist practice managers tonight, and the national standards I think fit nicely with what you guys are doing, because even if you're not looking to be compliant with the national standards, I think it's really good for you to understand why they were developed and what they can actually add to your business and to your work while we're at it, because I think they've got a lot to offer even if you don't want accreditation against them. So you can see there's some of the health services that we go across. So the national standards currently, we do everything from dental surgeries to aeromedical, the aeromedical space, as well as the cosmetic and medical services that are there around the middle of the health services. We're getting a lot of inquiries and a lot of cosmetic specialists also now wanting to have accreditation to the national standards. So the objectives of this session is to go through the actual standards and the scheme, to have a look just broadly at the structure of the standards, because the actual training to do the national standards goes for at least 40 hours. You can actually do it for free free if you're interested with the Australian Commission website. But then I want to talk about the top 5 non-compliance areas. So where sites are struggling around the country, because I think it's good to know that most sites do struggle with some part of the standard. So it's good to know where other sites are having issues. And of course, we can all learn from each other around some of our strengths and some of our weaknesses. So the standards came about with the Australian Commission on Safety and Quality in Healthcare. They have developed the standards and they give out the responsibility of actually doing the assessing to different agencies, of which QIP is just one. And you'll know, or probably be aware of ACHS as well, which is probably the biggest one in Australia. And then there's about 5 or 6 other companies as well that do assessing against the national standards. The Commission use the feedback about how well organisations go to the standards to then come up with additional ideas to help organisations and also to come up with additional educational material, etc. So the history of the standards is they were developed by the Commission in conjunction with the Australian government and the state health ministers. And so when we talk about the national standards and when we deal with the national standards, it involves the Australian Commission on Quality and Safety in Healthcare, but also the jurisdictions. So therefore, when we have issues on site, if an organisation's not done well, it's not just the Commission that become involved, it's actually the Department of Health as well. And as a lot of you would be aware, a lot of people's funding is dependent upon accreditation to the national standards. And again, the accreditation then gets reported to the jurisdiction or the Department of Health and the Commission as well. There's 8 standards, there was 10, and they revised the standards in 2019 and they brought it down to 8. Everyone thought having 8 standards was going to be a lot easier, but there's actually more in the 8 standards than there was in the 10. And sorry, we've got a question. Someone's asked, where do you go through to get the 40-hour training link? That's a great question. Thanks, Sean. It's on the Commission website, the Australian Commission on Safety and Quality in Healthcare. And I'm really happy to send the link via Avant, and that can come out to you guys at the end of it. It's really, really beneficial. Now, as we go through this session, what I would like you to consider is, even if you're not required to be assessed against the national standards, consider how these standards can still help you in your business. So these are, in my opinion, the highest standards that you can get in Australia at the moment. They are evidence-based and they are constantly updated. So if you are able to use these as some of your evidence base as well, it's going to help you in your practice. And I'll talk about that as we go through. So the next slide will probably sit on for quite a while. These are the 8 national standards, and I wanted to briefly talk about each 8 and do a quick overview of them and then discuss how that can possibly help in your practice. And we start off with clinical governance standard. And clinical governance is a big focus of the Commission. It's standard 1, and clinical governance is something that's really worth investigating if you've not been educated in this before. So again, on the Commission website, there's a whole lot of documentation, a whole lot of resources around clinical governance. But the best way to explain clinical governance is these are all the rules and all the processes that you've got in your practices currently. So this standard covers your policies and procedures. It covers doctor credentialing, it covers incidents, it covers complaints, it covers evidence-based practice. So if we have a look at a practice, like a small practice or a specialist practice, this is how you then protect yourself, if you like. So how do you then prove that you're using evidence-based practice? What do you do with complaints coming in? What do you do to ensure that people you're working with have got their registration, have got their Avant insurance? They have that nice little plug for Avant. And how do you keep on top of all this as well? When things go wrong, this is where you go to for your protection, if that makes sense. So it's fair to say that all of us as clinicians all have non-conformances. We all have incidents that happen in our practice. these are all your processes, your clinical governance. So do you have things like when a patient comes to see you, what's your admission process? How do you check that they've got allergies, that sort of thing? So clinical governance is where you have all your safety issues in here. Now, another part of clinical governance is also health and safety of your staff. It's also the checking of your equipment, your biomedical checking of equipment. Now, whether you're a small practice or whether you're, the Royal Hobart or the Sydney Children's Hospital, you need to make sure that the equipment that you're using is up to date, that it's been checked, that if you're doing someone's blood pressure, you need to make sure that the equipment's been biomedically checked and it's in date. And so I think when I was speaking to Anna Maria earlier prior to this webinar, this is where PracticeHub can come in to help you. Your audits, are you auditing your documents? Are you auditing your records? Are you reporting incidents within your practice? That sort of thing. You need all this recorded somewhere. You need policies. Your policies need to be referenced to the latest evidence base. And so that's where a product like PracticeHub can help you. You can keep all this in one place. If I come in as an assessor and ask you where the risks are in your practice or where the risks are to your patients, do you have a risk register? Have you sat down and thought about what the risks are to the patients in your facility, what the risks are to patients when they go home, what are the risks to the business? And the other part of clinical governance, which I really like, is the fact that they've also got staff culture as part of clinical governance. So even if you've got a small practice, do you know that your staff are happy? Are they well trained? Do they need additional training? Do they need training in life support, in basic life support training? All of that sort of stuff is around clinical governance. So this is all about the rules and the things that keep your patients safe and therefore us as clinicians safe as well. So clinical governance is a really good idea to have a look at the national standards for the clinical governance. And we'll talk later when we say, where do most of the sites have not mets in the national standards? The number one place where we have not mets is in clinical governance. And this is where a lot of our risks are. For us as clinicians and us as practice managers, we really need to get the clinical governance right. Now, the second standard is partnering with consumers. When the first edition of the standards came out, the partnering with consumers standard was what they called developmental, which was if you didn't get it, well, that was okay, you'd still pass the standards, but we'd sort of give you a sideways look. Now it's absolutely mandatory that we involve consumers in everything we do. And this makes a lot of sense when you think about it, and especially if you've got your own practice, I think it makes even more of a business sense for you to get a really good handle on partnering with consumer standard. And in essence, what the Commission says is consumers need to be our partners in everything from the design of the healthcare system. So when you're looking at offering your services, are you involving your consumers or your potential consumers in that? But also they need to be involved in the review of our operations and our outputs, which means, do we have consumer input into looking at our complaints and into looking into our incidents or our near misses? And this is something in health that we're not so good at doing. We're not so good at putting our hand up and saying, look, we had a fall. Can you come and have a look at this and see if we're missing anything? That sort of thing. So usually when we don't do so well in the partnering with consumer standard, it's around getting consumers having a look at evaluating our services and some of our not so good issues. This also includes any information that we give out to consumers. So for example, if you give out post-operative instructions or you want to give them a brochure that you've developed yourself in your practice, it needs to be run past consumers before we use it. Now, This makes a lot of business sense as well as making a lot of safety and quality sense, because you want to make sure that consumers absolutely understand what they're reading. We're so used to the medical language and we're used to what it is that you're writing, but a lot of consumers are not. And I just think of my own mother. I was talking to her yesterday, and a lot of people, if you think of your own relatives, have difficulty pronouncing some of the medical terms as well. So we really think that consumers can understand what we're saying and what we're putting in brochures, but a lot of times consumers don't. So it makes good business sense as well as safety and quality sense to have consumers look at your documentation, and they can give you feedback, even things like it's not big enough, there's too many words, et cetera, et cetera. The other part of standard 2 is around consent. And this is something, again, that some of us in the industry are doing exceptionally well and some of us are not. So with consent, we're looking at informed consent. And so it's the age-old question of how do you prove that you've given your patient informed consent? And I always like to look back, God forbid, imagine that you're in court and you're trying to defend yourself. Does your current consent, would that hold up, and would you pass the pub test? Let's put it that way. Would it pass the pub test that it looks like you've given consumers every chance to understand things that can go wrong with the procedures that we do? And interestingly, the Commission are so tight on clinical governance and partnering with the consumers that the first few actions of each of the rest of the national standards all have clinical governance and partnering with consumers in them. And then if that's not enough, the Commission have then trained all the assessors to make sure that when they're assessing the standards, they're using a methodology called PICMORS, and the C in the acronym PICMOR stands for consumers. So if that's not enough that they've written it into the standards, they're then making the assessors look at how consumers are involved in everything as well. So I can't stress the consumer side enough. And some people struggle with consumers. Who's going to be your consumer, especially if you've got a small practice? But you've just got to think it makes so much sense when you're running your own business to have involvement of your consumers or potential consumers as well.
And Amanda, sorry, just to sort of...
No, it's great, Anna Maria.
In some ways, it doesn't have to be, like, I guess with all of these things, there's a certain amount of being proportionate in how you do these things.
Absolutely.
I know a practice, some practices will do a consumer survey. I know a practice that does like a morning tea once a year and does like a focus group for yes, a group of patients. So there's lots of different ways of achieving these things. And I guess, what you do can depend on your type of practice or organisation.
Absolutely. And of course, to remember that the people with their bottoms on your seats in the waiting room, they are your consumers. They're relatives that have driven them in. They're also consumers or potential consumers. So you don't have to do, as Anna Maria says, it doesn't have to be a big song and dance. And it doesn't even have to cost any money, but it makes good safety and business sense. So thanks so much for Anna Maria. That's great. Now, the next standard is infection control. It's got a longer name than that, but I call it infection control because that's what it is. And this has been updated from the 1st of January this year. So the Commission revised just this part of the national standards in response to the COVID-19 pandemic, which we're all sick of hearing, I know, but it's been updated. And the big change, including things like more robust pandemic planning in the national standards, is that they've increased the focus in there on antimicrobial stewardship. So the requirements for antimicrobial stewardship, again, as Anna Maria said about everything else, it's all in comparison to the size of your organisation. However, because we're dealing with specialists tonight, my assumption is that there's going to be some antibiotics involved. This is all around making sure that you're prescribing as far as reasonably practical within the evidence base with the antimicrobial prescribing, and then having a look at things like the appropriateness of it and that sort of thing. And they also want us, and I'm trying to get my head around this bit, they want us to report our appropriateness to our consumers as well now. So that's how much they want consumers involved. So it is a focus of the Commission. It is a focus of health all around. So antimicrobial stewardship seems to be the big ticket item in Standard 3, as well as sterilisation. Now, this is where, obviously, if you're running your own practice and you're doing invasive procedures in your practice, I would urge you to have a look, at Standard 3 of the national standards, because this is your upper echelon of infection control. This is probably also one of the risks of your organisation. If you're doing invasive procedures, this is obviously a risk, infection control. And this is around whether you're going to, how invasive your procedures are, as to whether you need to comply with 4185 or 4187. And I'm sure a lot of the practice managers on here tonight will be all across that. But it's fair to say that, again, this is where a lot of the smaller organisations are struggling around sterilising. And so sometimes we're actually suggesting to people that you use disposable instruments if this is a big concern, or try and link up with your local hospital. So if you need 4187, that Australian standard has increased. And so sometimes you might be better off getting your instruments, like I said, processed elsewhere. The other really interesting part of infection control is our own immunisation. So what are your policies at your own organisation? I'm not talking about COVID-19. That's a whole nother kettle of fish we won't get into tonight. But are your staff at risk of hepatitis B? Are they at risk of getting measles, mumps, rubella? Are you seeing pregnant women, or are you seeing children? Then it would be a really good idea to consider having your staff immunised so that they're not passing on diseases or picking up diseases from your clients. So certainly in the hospitals and the day procedure units, we're really turning the heat up on organisations to make sure that the immunisation program is up to scratch. So that's probably a really good idea to have a think about. Now, medication safety, this is all around obviously prescribing. Again, the therapeutic guidelines will come into play here, but it's also about making sure that patient identification is done correctly. So again, it's about, especially in private practices, you'd want to make sure that you're documenting everything you're giving and that you're checking patient ID. So if you're going for accreditation, our requirement for National Standards accreditation is that you're checking 3 unique patient identifiers with medication, as well as having processes to report allergies if required to the TGA, and also reporting incidents of allergies within your own organisation or your own practice. And again, you'd want some system, your patient management system, to then hold that alert, if you like, to say that someone's got an allergy. But this is, especially when we get to know our patients well, we've got to stop and check and do the 3 patient identifiers to make sure that we're giving them the correct medication. The other issue that can come up here, and it has come up at some ophthalmology sites around the place, is who is giving medication. So are people credentialed to give medications? I think of an ophthalmology place once where they trained staff to, like clerical staff, to give eye drops, but you can't give S4 medications unless you've been properly trained. So it's around looking at your scope for that. Now, again, is that something we can keep in PracticeHub, Anna Maria?
It definitely is. So I think you could record people's training, keep a training log, and also have a policy and procedure around scope of practice, so that
as well,
people are doing, you are only working within with your scope of practice.
Great. Thank you. So comprehensive care, this is Standard 5, and this is what got all the groans coming out of all the hospital quality managers around the country. This is still very relevant to specialists and specialist practices. So this is where comprehensive care is like a mishmash of everything to do with looking after a patient. So in here we have falls prevention, We have pressure injury prevention, but we also have things like the end of life actions in here, as well as care planning. Now, even if you're running a small practice, it's a good idea to make sure that you're involving your consumer or your patient in planning of their care. Now, this is something that's done particularly well in specialist practices, but is it documented well? Sometimes I've seen the best clinicians just forgetting to document some of this. This is around including that you've gained their consent, you've discussed all the different options they have with them, and to make sure that's all documented. Comprehensive care also has delirium in it, and the issue with delirium is if you're doing anything with over 65s at all, it's a good idea to have a look at the Delirium Clinical Care Standard. In addition to these 8 national standards, the Commission haven't stopped there. They've brought out clinical care standards. And some of you might have been lucky enough to get on the training yesterday from the Commission. They brought out the Opioid Clinical Care Standard. So again, if you go to the Commission website, there is evidence-based best practice standards there. Now, in particular, there's one on invasive devices, intravenous cannulas. So if you're doing any IV sedation or anything like that, it's a really good idea to have a flick through that. There's also a clinical care standard on antimicrobial stewardship. There's a clinical care standard on cataracts, which has just come out. So if you're doing ophthalmology, it's a good idea to do that. And for endoscopy clinics, there is a colonoscopy clinical care standard, which is actually mandatory as well. So the Commission keep bringing out evidence-based practice. Now, this doesn't always go down so well with some of our specialists because the Commission are trying to get evidence-based, they're trying to get us all to do the same thing. You don't necessarily have to follow the evidence-based from the Commission, but you do need to be able to demonstrate that you're showing evidence-based. So comprehensive care is all around the actual care of the patient, the delivery of care, and then risk management. So again, as a patient comes into your clinics, you'll be asking them past history, medical history, surgical history, and you'll be looking for risks. So they're at risk of bleeding, falling, whatever it is you're looking at, you'll have a set of risk management documents that you're going through, and that's all part of the comprehensive care standard. Now, standard 6 is probably one of the smallest ones, and we probably think as assessors probably one of the most important ones, and this is communicating for safety. This is all around patient identification, this is around handover, and this is also around timeout when you're doing a procedure. Now, you can either be, again, running, the PA up here in Brisbane, or you could be running a one-man band, a one-woman band down in Hobart, for example. But the timeout and making sure that you've got the right procedure for the right patient should always be used. And this is a really good idea, practice for us to all get into. So assessors go into operating theatres and they make sure that timeout is performed before operation. So that's when the expectation is everybody in the operating theatre stops what they're doing, looks at the patient, checks the consent and make sure everybody understands what procedure is being done, and checking the patient ID to making sure that they've got the right patient, the right side. So if you're going to take my arm off, make sure you've got my left and right the right way. And this is something that I've seen over the last few years is absolutely getting better. So 5 years ago, if I go into an operating theatre, the nurses and maybe the surgeon would stop and do a quick check, but the anaesthetist would be still putting in the IV or something like that. Nowadays, you see a lot more people. The whole theatre needs to stop and make sure it's that safety couple of minutes to make sure you are doing the right procedure on the right patient. And why I've gone on and on about this is because I've seen this now come out of the operating theatre into other spaces, which I think's fantastic. And one that comes to mind is the delivery of chemotherapy in day oncology units. So again, places that have got, high risk of things happening, it's about giving ourselves permission to stop and just make sure we've got everything tickety-boo, especially if you're running your own practice. I would absolutely recommend this because this is your safety space. This is your safety stop to make sure that you're not about to do the wrong thing or the wrong patient hasn't come in, blah, blah, blah. Now, what the World Health Organization would say is that this should be done as close to the procedure or the operation, whatever you're doing, as practical. So obviously, if the patient is awake to be able to do this, that's often a good idea because they can agree that, you take off my right arm or whatever. If you have a look at most complaints, most incidents, and most serious events in health, they usually come down to or have at least in part a big issue with communication. So this could be us not asking patients the right questions to find out allergies, whatever, us not stopping and listening to the patients, or us not handing over properly. So not handing over, if you're in a day procedure centre or you're in a hospital, it's handing over to the next shift. If you're in private practice, it's about making sure that you're handing over care of the patient to their GP, making sure that as practice managers, we're giving our specialist all the information that we can. So it really is about giving ourselves permission to slow down and make sure we've got everything. And the big safety message in communicating for safety is to involve our patients in the handover. So gone are the days where nothing was my business, I'm the patient, I'm not going to know anything. The more we involve the patients and their carers, the safer that we are. Now, the blood management standard is standard 7. And it's fair to say that that's usually done very well throughout the country. There's only been a few not mets in there, but the big thing where blood management comes into its own is around blood wastage. So the big push in the blood management standard is not only, I guess, to make sure that the correct blood is given to the correct patient and training of staff that administer blood, etc., but it's about making sure that blood is only ordered for people that absolutely have to have it and making sure that we don't waste it. So for the specialists that are online tonight, especially if you're working in hospitals, etc., I'm sure you'll be getting reports in one way or another telling you how you're going with your ordering of blood, etc. And finally, the recognising and responding to acute deterioration. This is where our basic life support training comes in. If you're going for national standards, the national standards say that someone in your organisation needs to be advanced life support trained, or you need to have someone close by. So if you're running a small practice and you're not advanced life support trained, it's probably not worth getting the training, because unless you're going to use it often, you're not going to be competent or keep up your competency in it. So what I usually suggest for people there is just go into your Google Maps and see how far you are away from your nearest ambulance service. So sometimes that's a much better idea than to send staff off for training in advanced life support. But part of acute deterioration is also making sure that when we take observations in the practices, that we're using those colour-coded track and trigger observation charts. So anyone online tonight that is not using the track and trigger charts, I would thoroughly recommend, again, going onto the Commission website. They have the charts there. You can download them simply. But the idea is that if you take an observation and when you chart it, you put it on the chart. If it goes in the colour, not in the middle, but goes in the colour, that's when you need to escalate things. So you let the specialist know, or you call an ambulance, that sort of thing. So again, it's really safeguarding your practice to make sure that you're using evidence-based tools, evidence-based care, and it will protect you. It's also about yelling out sooner rather than later and patients getting into strife. Again, whenever we've looked at SAC1 events or really serious sentinel events where people have died or there's been significant harm to patients, we can always go back, and you will often see, more times than not, observations which show deterioration long before people sought help. And so again, I would thoroughly recommend that you have those, even if you print it off the Commission website, so that you know when to escalate care. The other thing that the Commission have written into Standard 8 is around patient escalation of care. So those of us in Queensland have probably heard of Ryan's Rule, and I hope if you go into a Queensland hospital, I hope there's a sign up there talking about Ryan's Rule. Now, Ryan was a young boy that passed away sadly at one of our rural hospitals in Queensland, and what happened was his mother knew he wasn't quite right. His mother knew he wasn't well, and she asked the staff around to do something, and they didn't feel that there was anything wrong with Ryan. So Ryan's Rule has subsequently come from, I think, a coronial inquest, I would assume. And what this means is, you know your loved ones, you know when something's not right. So Ryan's Rule means if my mother's in hospital and I'm worried about her, I'm then meant to speak to the nursing staff that are there. If they won't do anything, I can then call the Ryan's Rule. So there'll usually be a phone number or someone I can talk to. And it means someone will come out external from the people looking after my mother, and they will come and have a look at her. Now, you can still do this in your own practice. What you can do is you can have a modified Ryan's Rule, which means if you're a bit worried, please speak to this person or that person. If you're still worried, do this. It's a really good way to remind us that sometimes the loved ones actually know the patient better. Now, if you go to New South Wales, they've got REACH instead of Ryan's Rule. So it's good to think about putting this into your own practice, but also knowing yourselves, if you weren't aware tonight, that when you go to hospitals, either as a patient or you're visiting somebody, that these systems need to be there and should be there so you can escalate care. It's not about putting in a complaint and causing trouble because you don't like the sandwich or whatever. It is about getting a fresh set of eyes, or getting the people in the practice to stop and really think about what you're saying and to come and have a look. So that's Ryan's Rule. The other really big point with the Commission is it's not always our physical symptoms that are going to deteriorate. There's more focus now on mental health deterioration. And so it's having a think about, what do you do if I have a heart attack in your practice or I get chest pain, you'll call an ambulance. But what do you do if I suddenly show signs of deterioration in mental health? Have you thought about that? Have you got processes for that?
Probably a question for me is around, particularly with specialists, is clinical handover. So you made mention of reference. What standard does that come under?
So clinical handover comes under Standard 6.
Right.
Again, if you've got ISBAR is the common acronym or the common handover tool, again, I would really recommend thinking about using your handover processes with an evidence-based tool like ISBAR. And if you use ISBAR, that will fit in nicely. I think a lot of ambulances use a form of ISBAR, and certainly the hospitals use ISBAR as well. So that's where you identify situation, background, assessment, and your recommendation. And a lot of the specialists online tonight, you'll automatically do a form of that. If you haven't had training in that, you might want to even think about having your documentation set up like that, just so you don't forget anything. And often we like to train nursing staff and other allied health as well as non-clinical staff in ISBAR, so that we like to train them in that too, so that when they're speaking to the specialists, speaking to the doctors, then containing the information that they're giving to the doctors. So it sort of gives you a nice point, so you're not rambling on a bit like I am now. So yeah, really good point, because like I said, most of the really serious events come down to communication one way or another.
Before you move on, these standards were released, this is the second edition, released in 2019.
Yes.
When is there a kind of a time frame as to how often do you think updated, or is it kind of the minor updates on an ongoing basis?
Yeah, so I discussed this. I said they've updated the standard 3 at the start of the year, and I discussed the clinical care standards, but the Commission have another weapon as well, which is called advisory. So again, everything's on the Commission website, but just instead of updating, they will come out with an advisory, which is like an extra rule, if you like. And currently there's 33 of these in play. So for example, we were talking about sterilising before. The AS 4187 or ASNZ 4187 is the sterilising Australian standard that's used for, let's say, your more invasive medical devices. And that was updated, I think, 2014. Now, they're really hard to obtain to be compliant with those standards. And so the Commission did everyone a favour and put out an advisory, which was an additional rule, if you like, saying that we've got to the end of this year to comply with those standards. So, or something might come up and they'll come out with an advisory. So things can change. So there are minor changes like that, Anna Maria, which come out with an advisory, but we don't know when the next standards are going to come out. And it's fair to say, when we look at the next slide, not everyone in Australia has actually gone through this edition yet. When COVID hit, a 12-month hold was put on accreditation, and so we're all a little bit behind at the moment. Sorry, we've got a question there. Is an accreditation body for a non-hospital? The answer to that is that all of the accreditation bodies should do it. And I've got to be honest and say they can all do it. But hey, please email me. We'd love to talk to you. So at QIP. And I think my second slide we do a lot of non-hospitals. We do a lot of allied health. We do dental. We do a lot of different things. So I'd love to chat with you if you're interested.
And I think too, with the GP one, to access, say, the PIP Practice Incentive Program payments, yes, you do need the RACGP accreditation.
Yes, yes.
And then I think allied health and dental and that will be able to be accredited against the relatively new now primary and community care standards.
Yes. Look, there is a shorter version of these called the primary and community standards, but we don't know yet who exactly they're going to cover. So the first thing we say when someone approaches us is, are you getting funding from somewhere? If you're getting funding, please check with the person funding you which standards they want you to have. If in doubt, then I'm recommending these ones because these are the most robust, if you like. And that's why I'm suggesting that you have a little fiddle here or have a little look around the Commission website when you're looking for something or you're looking for evidence-based. These are the people putting all the time and effort in, and these are the people ruling the roost at the moment. So I thoroughly recommend keeping that on your favourites, the Commission website.
And I think too, Amanda, even if I know a lot of specialists don't need to be accredited, but sometimes being aware of these standards and I guess aligning your operations, yes, with them is really valuable. And whether or not you choose to get formally accredited, I guess the benefit of formal accreditation is around getting that third-party feedback, isn't it?
Exactly. And I will say too, I love this so much that I actually started up a free group, which you're allowed to join if you're interested, called Quality Managers Network Australasia. So I deal with a lot of quality managers around the country. And the idea of this was to get quality managers from hospitals mixing with dentists, mixing with mental health, everybody coming in so we can share ideas. And so that's why I'm sprouting this as your evidence base, if you like, but it's good if we share ideas. And we've even, a group of quality managers, we've even gone into aged care and we've done a gap analysis in aged care provider recently against these national standards. So the only thing that can come from this is quality improvements if you see where your gaps are, if that makes sense.
Yep.
So just to show you the scope of what we're talking about, and we're talking about the number of organisations in Australia that must be assessed. So these are your hospitals and day procedures, and currently that's 1,307. So even if this isn't your practice tonight, you need to know this because we are all consumers of health. So it's good that we know what our hospitals and day procedures are doing. So this is your ones that have to due to funding. Now, the percentage of people that have already gone through is 69%. I need to talk to you about within the national standards that we're talking about, there's 151 actions. So 151 things that hospitals or you guys have to pass. Having said that, some of the actions may be not applicable to some organisations. So of those actions, you can get either a met, which is what you want, obviously, you want to meet it, or you can get a not met, which is clearly not what we want, or a met with recommendation. So these standards currently, only 75% of organisations at the first time the assessors go in have got all of those actions or all the actions they're meant to have fully met. So this is why I say these standards are your top standards, and it's good if you aim for these, which means that some organisations need another visit to have a look at just those actions that are not met the first time around. Now, the other interesting thing, and I don't have this on the slide, but if we're talking hospitals only, public hospitals and private hospitals obviously are a lot different, but private hospitals must have accreditation to get funding from the health funds. And so a lot of you guys will be aware of this with your co-appointments with hospitals. And so interestingly, when you've got that financing attached to it, if we had this slide here to show who does better, private or public hospitals, at accreditation, the private hospitals are outperforming the public hospitals. Now, the Commission will say that the assessors haven't been as tough on the private hospitals. But as an assessor, and my previous role was with HealthScope, I will tell you that it's the financial penalty, the fear of if we don't get accreditation is, in my opinion, what pushes private to do a little bit better at accreditation. But it's fascinating to know that, isn't it? Now, the top 5 non-compliances: clinical governance, all our paperwork, mandatory training is probably the second highest thing at the moment. When we go into organisations, people haven't done their mandatory training, which is, I haven't kept up to date with my basic life support, I haven't done this, I haven't done that. That's a real problem because that involves money and time. Now, everyone is short-staffed around the country and stressed due to COVID and all the issues that have come through COVID. So mandatory training is usually a problem, but it's even more of a problem at the moment. And of course, risk management comes into clinical governance. So the number one non-conformance a while ago was risk management, which is in clinical governance. And this isn't around making sure we don't have incidents and accidents. This is around our processes to make sure that we are engineering down the risk as much as possible and making sure that we're managing it well. So that's where the clinical governance comes in. Infection control, a lot of issues around the 4187, around sterilising, and also now, like I said before, around immunisation. And we are targeting that. So if you look at places like operating theatres, people cleaning instruments. So if in your practice managers are doing your instruments, have they had training in how to do that? Have they had training in how to use your steriliser? And have they had their Hep B immunisation, and have you got serology to know that they are up to date with their Hep B? So all those things come into play. Medication safety, that makes me sad that that's a non-compliance. Comprehensive care, that's usually around our care planning, and the Commission are making sure that we've got evidence that we're involving our consumers in planning their care. So often that's our issue there. And partnering with consumers. It's fair to say, as an industry, we are still struggling with partnering with consumers. Having said that, there's some areas of really good excellence as well. The other thing that I haven't mentioned, which if I started, I would go on all night, is around Aboriginal health. And it's, again, one of my passions, but there are 6 actions within the national standards that are only regarding Aboriginal and Torres Strait Islander health. And so if you have that cohort of patients in your practice, then it's a good idea. There's even another little book that you can read around Aboriginal and Torres Strait Islander health, and it's all around us trying to reduce the gap. So we can see here, if you're interested, this is around how people went with the MET action, which I said you want MET, then how many people got MET with recommendation. Now, a MET with recommendation means you still get accreditation, but you've got to show improvement next time the assessors come around. And so you can see there, 21% of people had not met in clinical governance. So it's quite a bit in those actions. Blood management is usually pretty well done.
Do you think there's partly clinical governance so high because it is such a beast of a standard?
Oh, it absolutely is. And to be honest, that's where we really need to put our energy in as an industry, because we're usually too busy trying to care for the patient. We think we're doing the right thing, doing the practical stuff, when in actual fact, we do need to put a bit more time into the clinical governance, because I always view things as a numbers game. The more patients you see, the more likelihood you're going to have an adverse event, and it's not always our fault. Sometimes it's avoidable, sometimes it's not, but it's the clinical governance, it's the work that goes in there that will theoretically reduce the chances of that happening, but also will absolutely increase our protection and even our conscience, if you like, to know that we did everything we possibly could. So that's why things like, all that governance stuff comes in there, your mandatory training, your risk register, all that sort of stuff. Now, these actions may not mean that much to you. However, this is a list of the top actions within the standards that got not met across the country. And number 1.8, so it's clinical governance because it's standard 1, and 62 organisations got not met since this started, and 62 organisations also got not met in 1.10, which is risk management. And 1.8 is quality improvement. So this is about auditing. So what do you need to audit in your practice? What is high risk in your practice? Are you even auditing the fact that you're gaining informed consent? Are you auditing that you're doing observations on patients if they're meant to have observations? Are you auditing that you're doing follow-up phone calls if that's one of the things in your thing? So what are the risks in your organisation, and what are you auditing to give yourself assurance that A, it's either happening, or B, if it's not, that's okay at this stage, but please do a quality improvement to try and fix it. So again, this is where Anna Maria's system can come and help you. You can have little audits set up. I'm assuming, Anna Maria, have your audits set up, and you can align that with your quality improvements. So if you've got a complaint from a patient, is it something, they're complaining about something that you've audited? It's about getting evidence. It's around continuous quality improvement, keeping an eye on the shop, as I like to call it, and just making sure you're doing everything as reasonably practical as you can. The safe environment, the next one, we're having a field day at the moment going around organisations and handing out not met, sadly, in safe environment. And a lot of this has to do around staff safety. So it's around fire training, evacuation. Have you had a little mock go at evacuating your practice? Have you had to think about someone, an angry person coming in with a knife even, I'm sad to say. But I remember years ago when I was young, down at the Mercy Hospital down in Melbourne, we had an angry patient come into the doctor's practice, actually consulting suites at Mercy Private, with a gun. So have you got plans like this? Have you got a plan for people acting out? And if you've got staff that spend a lot of time on the phone, if you've got less than lovely clients sometimes it's around making sure those staff have had training in de-escalation and that sort of thing. So it's around looking at what your risks are to yourself and your staff as well, and making sure you're providing, it's the WHS thing, as safe as reasonably practical, and we do make sure that we're looking to make sure it's reasonably practical. If you've got staff working by themselves, after hours, have they got an alarm or something to ring. The other thing is, if you've got, this also ties up with your equipment as well, so making sure that everything's checked. We've been in facilities where there's not even exit signs and fire alarms. We've been in facilities where the smoke detectors hanging with no battery in it, that sort of stuff. So all of that is all part of clinical governance. And so then we go down, if we have a look for standard 3, the highest not met that was handed out is again around antimicrobial stewardship. So again, it's something that a lot of clinicians don't want to hear about, but it is a hot topic for health at the moment. So I put this slide in here just to say this is around medical officers in particular. So what sort of questions do we normally ask the specialists? And this can either be in your own practice, or this can be in your day procedure, or even hospitals. So we love to ask about governance around, usually ask if it's a big facility, we'll ask medical officers how they participate in clinical governance. Does the organisation listen to you? So if you're in a practice of more than one medical officer, we'd be asking what involvement you had in the governance. If you know how to access policies and procedures, do you know how to deal with complaints where they're recorded? What sort of incidents you have? And open disclosure, another hot topic. We're looking to see if people have had training in open disclosure and how also that's documented in your practice as well. Risk management, of course, 101. So if this is your own practice, we'd be asking you what the biggest risks are for your patients and also your staff. Credentialing, we can thank Dr. Patel for that. That's still a hot topic. And scope of practice. Now, we are looking in hospitals, we're making sure not only that that's done, but we're asking questions like, say, the nurse unit manager of operating theatres, are you aware of the scope of practice of people that are on your operating list, that sort of thing. We're seeing, especially now with shortness of staff around the country, we're seeing people acting outside their scope of practice and assisting in operations or procedures where they may not be qualified or trained to do so. And we're also seeing the odd practice manager sometimes who's not been trained doing observations for patients, that sort of stuff. So scope of practice, again, whilst I'm talking accreditation, this is the sort of stuff that keeps not only patients safe, but keeps you safe and keeps your registration safe as well. Consent and timeout, we love watching that. And obviously you'll know when the assessor's in the room watching that. And interestingly, last week I was helping an organisation get ready. I was in a little hospital, a little rural hospital, and I asked the nurse unit manager how well the timeout was done in her operating theatre. She was the operating theatre nurse unit manager, and she said it's the best she's ever seen in Australia. And I thought, well, thank goodness for that. So I went into her theatre, she knew I was there, and they were doing a colonoscopy, and they knew I was coming in. The surgeon did a beautiful timeout, stopped and did everything. The scrub nurse stopped and did everything. But the nurse unit manager who was in there as the anaesthetic nurse kept doing stuff, as did the anaesthetist, after she just told me, it's beautiful here, we're fabulous. So it just goes to show, you know, when we're busy, what we actually let go. But that's the safety thing. It's not just protecting the patient, it's protecting us as well. And I'm not trying to have a go at her, because I can see myself doing the same thing. What we think we do and then what we actually do when we're busy are two different things. Mandatory training. Now we love picking on medical officers and asking them if they've done their mandatory training in the hospitals. And we'll probably pick on you too in private practice to see if you've done, you know, what training you've done and if you're happy with that. Now the clinical care standards, I spoke about that before, and the evidence base. So especially colonoscopy, the Commission put out one of those advisories I was talking about. So anyone doing colonoscopies has to adhere to the colonoscopy clinical care standards. But part of what we ask due to the national standards is not only are you aware of the evidence base and are you using it, but the Commission actually require that you're having a look at how your practice varies to your peers. And so a lot of specialists are outstanding at doing this in their own practice. However, if you're a small practice or you're a sole practitioner, sometimes it's hard to compare your outcomes to other people. So sometimes you need like an outside peer group, or you might send off indicators or something like that. So it's about making sure you know what your error rate is, or whatever it is that you do, how it varies, or where you stand in relation to your peers as well. So that, again, is a really good thing to know, and a lot of our specialists are really good at knowing that. Thank you. Have we got any questions? I hope I haven't bored everyone off to sleep. Are the standards for specialists the same standards for GPs? Well, the answer to that is it's up to your funding and what you want to do, but generally no. Generally no, depending on what procedures you're going to perform within your practice is the best thing. So if you want to ask a specific question, please feel free to contact me. Only too happy. I think my email's there, so please feel free to email me. But the first thing I will ask you is, are you receiving funding from anyone, and what do they say? Now, GP standards, one thing, but some GPs also use the national standards. A great example of that is if I look at prisons, take prisons, for example. Some prisons in Australia with health services, not the prison part, but the health services, some of them use national standards and some of them use the RAC GP prison standards. So it really depends on your jurisdiction, and it depends on what you're trying to achieve and your funding. But no, they're completely different standards.
I think that they're different, but there's a lot of good information in both. And I know we at PracticeHub, we provide a suite of policies and procedures, and people often sort of go, oh, it feels very GP centric. And I think it's partly because those are things that any type of practice needs to be considering. And so there is a bit of crossover. It's, that the national standards are sort of very differently structured, but there's a lot of good processes that the GP standards have that are really valuable for any type of practice. And a lot of the college resources too, the GP college resources are very good.
And look, I think the best way to learn, someone came on early and asked for the link, and we'll send the link for the training. The best way to learn is to do the training, but also consider coming and being an assessor too. I've learned when I started assessing, that's when you learn more. The more places you go and see, the more good things and bad things you pick up. None of us are perfect, but the more you see and the more you come to these sort of webinars and talk to other people, you can share ideas and pick up other ideas. So like I said, that's why I started the Quality Manager Network, because someone in a slightly different industry to you might have a really good idea that'll work well with you. So it's just good to hear other ideas, I think. Thanks, Anna Maria.
Thank you. I'm going to move across and do our demonstration of the PracticeHub site. So in the bit of time we've got left, I'll just go through. If you're a PracticeHub customer already, then this will all look very familiar to you. If you're not, you'll get to see now, I guess. So I was thinking a lot about Amanda's presentation, and one of the key things that I really wanted to go through was show you the ways in which you can store and track your evidence. And Amanda and I had this conversation earlier, and I said one of the beautiful things about PracticeHub is it allows you to systematize these processes. So very much in terms of one of the things you mentioned there was policies and procedures. So within PracticeHub, you can have all your policies and procedures in one easy to find place. So for example, medication safety, you've got your policy and procedure relating to the safe and quality use of medicines. And then the other thing that is really useful is, again, linking back to the relevant standards. So why you do what you do, and you can link your policy and procedure to the relevant standard. So if I click on that link, you'll see that will take me directly to Action 4.01, which relates to that particular policy. And the benefit of that, again, if you're preparing for accreditation, but also just for awareness, I think, for your team so that they go, well, why does this policy say this? Why do we do these things in this way? Because this is considered best practice according to those national standards. So it's a good way of putting that information there. The other good thing, and I think something that's a challenge for a lot of practices, is being able to get your team to sign off that they've read and understood policies. So I guess the old school way is emailing them out or handing out hard copies, collecting them all, working out who missed out, and so on. However, with something like PracticeHub, quick change, and you can select which roles in your organisation need to sign off on a particular policy. So I'm just basically saying everyone in this instance. I'm going to save that. I'm going to notify them. Test for now. And now when those users who have those particular roles, when they come into the platform, and in fact on the dashboard, they'll have an alert that this policy needs to be signed off. They'll see these red banners on there. So you're required to read this, and then down the bottom, it'll have the name of the user, have read and understood and agree to comply, and they press confirm. And now you basically have a digital track of the fact that they said they've read this policy and agree to comply. If you update the policy at some stage, again, same process, just these roles are already ticked. You'll go in, you'll save it, you'll do a notification, they'll get prompted yet again, basically saying the policy's been updated, please go back through, read it again and sign off. So when someone like Amanda's, an assessor, comes in, she can go in and she can say, show me how many people have signed off on your medication management policy. So I can go through, oh, it's a bit big. I can click on my archived, I can look for policy, and I think it was safe. Quality use of medicines, so trust that. Oops, that one. And you can clearly see if I found the right policy. And they can see, oops, which policy it hasn't. Ah. No, sorry, apologies. Anyway, they will be able to see that on this date, this user signed off on this policy. And anything with an X basically says that's an old version, they signed it then, but now we should have a new version signed off. So having that traceability, no one can say, no, I didn't know about it. No, you never told me. And again, I think, as Amanda has highlighted a lot, it's about protecting you as practitioners, as managers and owners, to be able to demonstrate that you do share this information, that it is current, and that your team has actually, you have a process for tracking that people have signed off on it. So that's a good way of being able to do that. Now, with our layout here, you could align all the content back with the standards. Some of our GP practices prefer to do that. Otherwise, this is very much a kind of, we start you off with a certain layout and content, including a whole lot of stuff around infection control, which has been written by an infection control expert. And once again, you can link all of these policies to their relevant standards. Other things you can do, you can create regular tasks. So Amanda, I remember you saying the one about the safe environment. So one of the things I would do if it were my practice, I'd probably create a task that related to doing a check of the physical environment. And we do have some on here. I might just see.
I love your cleaning audit there too. That
cleaning audit, that's exactly right. Yes,
perfect.
exactly. Well, let's pick that one for now. So we select that. And look, we even include what we think are what documents you should attach to this, how often it should be done and who it should be assigned to. It's a bit of a serving suggestion. You can basically make your own choices. But in this instance, we've even provided some steps as well. So that saves time, but then the practice can update that as they want. But having done that, I'll be able to say, all right, that's an administration task. And we want to do this every month as suggested, and we'll do it on the first Wednesday of the month. Now, who am I going to get to do this task? Well, I can select an individual, but personally, I'm a fan of picking roles, and we can say, okay, as long as one of these people does this task will be good. and can be read by anyone assigned. So that means that if somebody's on holidays, somebody else could pick it up. And again, if you are assigning it to an individual, you can allow them to reassign it so that when they're about to go on 4 weeks leave, everything doesn't fall in a heap while they're gone. They can go, okay, what are my tasks that I've got coming up? Who can I reassign them to while I'm away? So as I say, I think tasks are a really good way, again, of systematizing that approach of these are the things we need to do. You could add those audits. So I think there's things like medication audits, all the various different audits that you do, you can include them in here. And then you can also attach any documentation that is relevant to that particular. So here's my template for the environmental cleaning audit, and I attach that. So the person who comes along to do this task is equipped with the documentation that they need, so they can print out that template or open it and do it electronically. I can also cross-reference this with a policy. So if I just search for cleaning, let's pick that one there. Try that one as well, why not? So we can link all this information. So we're kind of creating this information ecosystem around this. These are all the things that somebody who's responsible for these actions, here's all the information they need to successfully complete this task. So I've saved my task. And I think it's one of those things that it's nice you don't end up sitting up in bed at 3 in the morning going, oh, far out, we forgot to do such and such as well. Amanda, I know another passion of yours is about equipment. So
can I just say too, Anna Maria, what I love about this too is that if you're the practice manager or you're the owner of the practice, you can then look to see are things getting done, because that's another big issue, is that especially busy clinicians don't necessarily know when things aren't being done. So that's what I love about this system as well. So it makes everyone sleep better at night.
I think so, definitely. And as you were saying, you know, how do you know all your diagnostic equipment or all your clinical equipment and even your office equipment?
Your sterilizers, yeah, have they been validated? Yeah,
exactly. So in my experience, people often put the reminders in Outlook. They have an Excel spreadsheet with their equipment, and then they keep all the documentation in hard and soft copy somewhere else. The equipment really just allows you to have all this information in one place. So in here, I can put a description in. We've just kind of put some, not the sterilizer information, but generally things like your serial number, the model number, where is it kept? So it becomes a bit like your asset register. Is it owned or is it leased? You know, and what information do you have in there? And then when it comes to maintenance, how often does it need to be done? Who is the supplier that does that for you? And that's so helpful, because I suspect a lot of the time practice managers are constantly being asked, who does that? Who looks after the sterilizer? Who does the cleaning? Who does this? Who does that? They can see all this information in here. It's easily accessible. One of the things I like to recommend is actually putting a link to the user guide, because most user guides or user manuals for equipment nowadays are online. And again, instead of having a drawer full of little booklets, you can actually kind of put a link in here, which makes it much easier to go and find that information. If we put all our details about when the maintenance is due, we'll get a reminder. We can flag when the next maintenance has been booked. Again, we know with our sterilizers, they need certification or calibration. So again, you can set up that information for the equipment if it's relevant. And once again, you could include and attach all your documentation relating to your validation reports.
But that's just invaluable, Anna Maria, especially, you know, you need your evidence there. People are looking for the evidence. That's just fantastic.
Yes, thank you. Yeah, it is good. I think it is. And I just think it's so nice. It's all there. And look, once again, we've attached it to some policies that relate to sterilisation. If I had a contract with a technician that came out and did this information, we have a contract register, and I would link that in here as well. So once again, connecting all the pieces to be able to say, just checking we don't have them. I'll just pick one at random. We'll do that one just so you can see the process. So now I know that that contract relates to that piece of equipment. So you've got all of these things all tied together, And look, it doesn't take a long time to actually do this. It's just uploading the content and then just connecting it up where necessary as well. So I think, from the point of view of equipment, which is just so critical, and obviously an important part of the assessment, the equipment register is really valuable. And as I mentioned, the contracts register is also very similar. Let's quickly save that. Contracts register, insurances for your business. So, if you've got vehicles, if you have your practice indemnity, your business insurance, all of that information can be put in there. And again, putting those reminder dates in there so that you get those alerts when they're due. Also built into PracticeHub are some training modules. And again, for private practices in particular, it can be challenging to find the content, to find the time and that sort of thing. But there are 8 modules already set up within PracticeHub that you can assign to your team based on their role. So, things around health records, privacy, risk, infection control, work health and safety, and so on. So these are really good. I suggest they take probably 45 minutes to an hour to complete. And one of the things I recommend practices do is do the modules, do the content as a group. So if you have a staff meeting or something like that, you can actually do the content together. And then at the end of the module, your team can go away and do a quiz at the end. And I think this really nicely supports the signing off of the policies. So if people have signed off, yes, I've read and understood the privacy policy, wouldn't it be nice to have that peace of mind that that knowledge has been tested? And that's what these training modules can do as well for them. So again, I know there's mandatory training, but there's also this ability to sort of basically be doing this continual development for all of your practice team as well. So the next one I'll show you, and Amanda, I'm sure you'll enjoy the APRA Alerts application, which is basically a daily update of your APRA registered practitioners, new and active, to confirm their registration status. So if our practitioners suddenly had a stipulation on their registration, you'd be alerted and you'd be able to go in and have a look, and that might affect their scope of practice. And so rather than waiting to be notified by a practitioner or stumbling upon the information, this feed of just basically putting their APRA number in will regularly come and alert you if there's any changes to their registration. And it's for anyone that's APRA registered. So practitioners, nurses, allied health, anyone with an APRA registration can be added in here and you get that information. And I think that, I know maybe in smaller organisations it's not such a big deal, but I do think it is nice because it does give you huge peace of mind that if anything changes, you know straight away. And again, I think it's a risk management strategy. Closely tied in with that is our certificate of insurance application. For Avant insured practitioners, they can actually consent to just automatically sharing their Avant insurance details into the platform. Again, a bit like the APRA alerts, if anything changes, you would know. For practitioners that aren't insured with Avant, you can still add that information in there and they'll still be automatically prompted to send their updated certificate every year when it becomes due. But it's a very simple process in terms of them uploading it or you uploading it as well. So I think, again, in terms of that, are people appropriately registered? Are they insured? All of that sort of information is all in there. Now, one thing I didn't mention, which Amanda, you mentioned before, was about registers. And of course, that is a very good point that I should have mentioned back in the manual. So if I search register, we actually have templates for different types of registers, for significant incidents, your complaints register, organisation-wide risk register, and your quality improvement register. And I often think that these first 3 usually lead to something that can be added to the quality improvement register.
Absolutely.
Yeah, so you've had a complaint, so maybe, based on that complaint, you're going to change the way you do certain things. And again, I think it's kind of a proportionate approach. So yes, this is not necessarily what the Royal Brisbane is going to use, But in a private practice, I think the main thing here is about recording this information and having that there, and so, you know, what happened, what action have we taken, and so on. I'll just scroll along, you know, what have we done, have we signed it off? And then that will then potentially move into the quality improvement register. You know, the patient waited a long time on the phone to get their results. So I'll just move that, length of time on the phone. What are the actions we've taken? And then if I go back, I can see in the quality improvement register, the reason for the change. So we're going to update the on hold message, suggest they call at this particular time where we'll have a nurse rostered on and they can do results, etc. So very much one thing linking to another. Other things that you can do in here is put in things like your standard agendas for your meetings, which I think would include things like reviewing your registers. I have set this as a reminder every month to come in and have a look. What have we added to the register? What do we need to talk about at our next meeting and make part of the agenda, and then the minutes? So all of that can all be put in here as well. I'm very familiar with general practice where often the quality improvement register is a mad dash just before accreditation. And it's a shame because in my experience, practices are always improving what they do. They're just doing it without thinking this is a quality improvement, as they're just doing better and don't think to document it. But this is a simple way of being able to do that. Within PracticeHub, we have some resources that we think people will find useful. The one I particularly like to show is the ones around position descriptions, because I know this can be the bane of many organisations. You know, we've decided to hire an office manager. We need a position description. You can download these, and I tend to think they take you kind of 80 to 90% of the way there. It's certainly better than, there we go. It's certainly better than starting from scratch and basically going through what are the requirements in terms of what do we need this candidate to have or this person, and what are the expectations. So again, that's an additional benefit in there. There is also, there is an agenda. Find it. There we go. So there's this meeting agenda. So once again, one of those things that practices often, you know, would say to me, but what would we talk about? It's like, well, if you have a kind of standing items on your agenda, have you got new policies? Are there personnel things? Have practitioners got specific requests? And I know, having read minutes of many meetings, that often is a big topic. Work health and safety. Amanda, as you were mentioning, consumer feedback or patient feedback can be in there. What feedback have we had? Things from your registers and so on. So it's really useful to have this information and then to create the minutes, which you store in PracticeHub. And then they're available and accessible to everybody in your team to read through. So whilst they may not be able to attend every meeting, they can do that. As we are virtually out of time, I will tell you one last thing. As you mentioned, Amanda, you know, it's good for clinicians to know what isn't being done or what has been done, but most importantly, what hasn't been done. And the dashboard will that. Yeah, so these are things that this particular user that I'm logged in as needs to do. But this team alerts and tasks column is really valuable in terms of keeping track of who's not doing what they need to do, and makes it a really simple process to follow up with that. All right, as I lost track of time while talking, I will move along to the quick slide on the next steps. If you're already a PracticeHub client, contact us if this has triggered any questions that you want to ask us about the product. If you're not, the best way to find out more is to visit our website and to book a one-to-one consultation with one of our team. There's lots of really good articles on our website, particularly around a recent one we did around complaints and things like that. And all our webinar recordings are also on the website. There's our contact details. And lastly, Amanda, can I thank you so much? I was absolutely riveted. You're an incredible wealth of information. So thank you so much.
So lovely. Thank you. Sorry if I spoke too much, but please always yell out, because we've just learned so much from each other. I think that's the best thing I like about health, is that we're always trying to do better. So yes, it's fabulous. Thank you.
Fantastic. Thank you very much. And thank you to all of you for your attendance and your time this evening. And I hope you enjoy the rest of your evening, and we hope to see you at our next webinar.
Thanks, everybody. Bye-bye.